Yeah, so Dr. Adrian, you're most welcome. And Dr. Adrian will introduce himself, although I will mention that he's the head of clinical services at the Lung Institute. He's a physician by training, and he will kick us off this afternoon. And before Dr. Winceslaus Katagira joins in to take us through the pulmonary rehabilitation aspect. So Adrian, you're welcome to project your slides and let us know when you're ready to start.
Yes, good afternoon to you all. I hope you can
Good
hear me.
afternoon. We can hear you very well.
Okay, thank you. Can I go ahead and start?
Yeah, you have 15 minutes at most. Thank you.
Okay, thank you. Colleagues, I welcome you to this day of lung science. And today we shall be discussing pulmonary rehabilitation, but we shall begin with the bronchiectasis and look at the impact of pulmonary rehabilitation in enhancing quality of life. And Adrian Mwota, a physician and a research fellow at Lung Institute, privileged to lead MLI clinic department. So in this presentation, we shall briefly look at just the bronchiectasis, the fundamentals, look at biology, look at the different causes and phenotypes, microbiology, look at some assessment, speak about quality of life and function, and the diagnostic workup, and then the rehabilitation roles and possible directions in this. So to set off bronchiectasis, they that manufactured the word, if I'm to say, it looks at two components. One which is means the airways, and then the other which talks about the stretching or the dilatation. And it being a permanent airway dilatation, it is mainly diagnosed by the HRCTs, and it is not only by symptoms or by X-ray. And on HRCT, it is key that some of the things that point and really key in making this diagnosis, one of them is a signatoring, which looks at a bronchus which is dilated. And the image right here just looks at that signatoring, if I would say more of a diamond, a shape on top of a ring. And the others include the tramline tracts, which are thickened bronchial walls. And in severe cases, we even see cystic changes and changes in the lung pathology. And this is significant to rule out because it is usually an unreversible condition which is managed. And these are also patients that fit the chronic respiratory disease phenomena. It is one of, if I would say, one of the conditions that may be underlooked or not given much attention, probably sometimes because it may pre-exist among other diseases. So when we look at how common is it, the map, as we see, it shows that one, like I mentioned, it is of importance, but we do not have much evidence. And that would fit in probably among the forgotten, or among the forgotten, some of the forgotten diseases. And as we see and look at this, that in blue, we have the available data. And the one where we have that shade of gray, it is where we actually have no consistent data by the time the the author was actually drawing this map. But we see commonly in areas that is the United Kingdom, the USA, Italy, Catalonia, and also Germany, and also the areas of China and South Korea, parts of Asia, but locally we do not have much data to guide and to help. But regardless, when we look at it, we see that about 600 and about 67 people per 100,000 affected across Europe. And this is from an EMBA-RC study looking at bronchiectasis, and it is across 28 countries. So when we come locally, some studies have been done, and this is just to point out one study which was done in Cape Town, looking at how many people that are attending the respiratory clinic actually do have bronchiectasis. Like earlier on mentioned, we have dilatation of the airways. So this was a retrospective study done in Cape Town, South Africa, looking at a pediatric population from 3 months to 15 months. And we looked at these people who are attending the respiratory clinic. And from the findings, they found that 17.2% of these patients actually had bronchiectasis, diagnosed, remember, by a CT scan. And the common causes, as we see, included post-infectious causes, extending to the immunodeficiencies, that is HIV and other primaries and secondary. And among the post-infectious ones, post-TB seem to rank highest. So from the pediatrics, when it comes to the adults, one study that was also done in Africa, it is one that is in the farther eastern of Africa, that is in Somalia, where they also looked at patients that had actually attended or had undergone an HRCT study between 2021 to 2022. And they also found that approximately close to 50% of these they would actually meet the criteria of bronchiectasis. So with this, some of the major causes from this, we have the role of inflammation. We have the role of other complex heterogeneous comorbidities like rheumatoid arthritis, other idiopathic causes, and across Africa and areas which are heavily burdened by tropical diseases and infection, we find that post-TB bronchiectasis actually ranks. So when we look at bronchiectasis, we are looking at the vicious cycle, which plays a key role on how bronchiectasis comes. So we find that we have an issue in insult to the airway, which could be an infection, which could even be at genetic level or associated immunodysfunction. And from this insult, it will actually lead to a state of inflammation, which may initially be acute but can go on to actually be chronic. And in this state, it's usually the chronic inflammation. And from this chronic inflammation, due to the different changes that are involved, we find that we shall actually have an impairment in the normal function of the respiratory tract, which is the impaired mucociliary clearance. And with this, we shall actually have a stasis leading to mucus hypersecretion and obstruction. And these further can actually lead to colonization, microbial colonization and infection, which will further on infect the airway, leading over a long period of time. This leads to a remodeling of the airway, giving us a dilatation and also a destruction. And this cycle is very important as it will be one of the key areas for us to actually, as we are approaching this, to interrupt. This slide just talks about the different forms of bronchiectasis, which could be from cylindrical to circular. So this is a bit more morphological, but phenotypically, we have those that can be categorized probably according to the complications like pseudomonas, and then others can be categorized according to their chronicity of how often they may come up with the symptoms. And then this may actually give us phenotypes where we have things like dry bronchiectasis, where we actually have actual evidence, but symptom-wise, we're not having a sufficient sputum production. This presentation here just tries to emphasize and give us a difference. So we see this is the normal airway, but this down here with the green looks at an airway with bronchiectasis. You remember that due to the changes that occur with abnormal mucus clearance, we have this stasis, which is continuously localized. So with that, we look at the different contributors. Like earlier on mentioned, the post-infectious from the pneumonias that faced an early childhood to the TB, to measles, but also to the genetic, where genetic we actually have now the different categorization of cystic fibrosis and then non-cystic fibrosis. And in the sub-Saharan Africa, attention and clinical attention looking at the non-cystic fibrosis, it being more of a common down the Sahara region. Then the different immunodeficiency syndromes, the connective tissue, and then others like chronic that may lead and contribute to the chronic inflammation. This schema just points out, looking at the different patterns of post-TB, just to point out that bronchiectasis is also one of the actual syndromes that are actually clinically significant in post-TB lung disease. With stasis, definitely the emphasis and importance would come to the changes in the microbiome of the lung microbiome. And one of the major key importances is that the major key areas of focus is the pseudomonal colonization, it being that we have this continuous phase of stasis, recolonization, which would trigger the chronic use of antibiotics. So pseudomonal colonization is one of the key areas when we come to airway microbiology. Clinical features, like we mentioned, we have patients coming in with consistent cough. This cough is productive. It's continuously on a daily. They tend to have recurrent infections more than twice a year, and these would require antibiotics. And this can actually be seen by the color of the sputum. We know as we tend to green from the shades of white to yellow, they definitely have a significance when it comes to bacterial colonization. And definitely they will actually come with a varying degree of dyspnea. Also important, you may actually see patients that are coming in with a digital clubbing as one of the presenting signs that we see on examination. But among them, the commonest, patients will have fatigue. Depression and anxiety may be underdiagnosed, but are also present among these patients. So with these patients, once you have them and you have actually confirmed from the HRCT, you need to actually now sort of investigate, go back and do the different investigations from baseline investigations like the inflammatory panels from CBC, CRP, ESR, doing a sputum culture and sensitivity, okay, doing the immunoglobulins if you want to roll out the immunodeficiencies, and actually also screening for also aspergillus and other fungal possible colonizers due to the given cascade. Also, a baseline spirometry can actually also be done, ensuring that we actually the patient actually meets criteria for spirometry. In case they do not meet due to the nature of the rate of infection, this can actually be postponed. And then we have the targeted testing, where you can actually screen for the connective tissue disease, for cystic fibrosis, and also for cardiac comorbidities, and also allergic rhinitis, and upper airway irritations, and upper GI irritations like esophageal reflux disease. So with this diagnosis, one may want to go ahead and look at the severity. Some scores have been suggested. One is this bronchiectasis severity score, which is able to point to a degree and risk of mortality. Others like FES and EFEST, which look at and also consider the FEV1, the age, the colonization, and the extent, and the dyspnea. So with this, one can actually be able and probably can anticipate the risk of mortality. And as the lower, definitely we know at 5 years, we have the lower risk of mortality. So when it comes to treatment, above all, this being a chronic disease, one of the focuses is patient education. The patients really need to know what the disease is, and they would have to know that this may have no cure, but the symptom resolution can actually be focused on to help them have a better quality of life. Then definitely the general routine for chronic respiratory disease patients, the vaccinations, the nutritional support. So those that are smoking should actually be assisted in smoking cessations. Targeted, we can look at bronchoscopy for obstructions, and look at the replacement in case of deficiencies for immunoglobulin. And then for those with the upper GI comorbidities, they should also be addressed accordingly. In treatment, airway clearance is one of the major pillars when it comes to managing bronchiectasis, it being a syndrome with increased sputum production alongside the cough. So there are different modalities of clearing this, from the non-device to the non-device-based to device-based. And this can be like with exercise, participating in active cycles of breathing, yes, and then managing the complications, managing the infection. This would bring in a conversation that probably we may discuss at a future time, but antibiotic, the rationale of using the oral, the point of using the nebulized, and then the rationale of the prophylaxis among these participants. In efforts of ensuring that we have a clear airway, we also see the blended use of mucoactive treatments, and these will include the mucolytics. We know the N-acetylcysteine, the hypertonic saline, and also the mannitol, and these are used as part of the comprehensive treatment when it comes to airway clearing for these patients. And in here definitely is the pulmonary rehabilitation, which would actually focus on managing the patient completely. So in short, as I come to the as I come to the end of my presentation, bringing to you the bronchiectatic patients. And in bronchiectasis, one of the major key areas of focus, which is the vicious cycle that from all over the world, all efforts are being made to interrupt this cycle as a way of focusing on treatment, right from preventing the initial infection, which will lead to the chronic inflammation affecting the mucociliary clearance, leading to mucus hypersecretion, leading us to routine or increased risk of colonization, which then goes ahead to give us the airway dilatation. So with this focus, that would be how to approach the bronchiectasis. But with this, allow me end here. I think the next session will dive into and focus on the role of pulmonary rehabilitation in managing this.
Thank you very much, Dr. Adrian. A round of applause wherever you are for Adrian for that very exciting introduction to bronchiectasis. At this point, I'll ask you to, then I'll ask Dr. Katagira to join in, and straight away we continue in the interest of time. You're most welcome, Dr. Katagira. Thank you very much, Dr. Adrian.
Thank you. Kindly confirm that you can see my slides in presentation mode.
Yes, we can. Thank you.
All right, so just allow me some bit of time to take away the loading controls. All right, so thank you. My name is Dr. Katagira, based here at the Lung Institute. And so I'm just trying to hide these floating controls so that I can see everything well. All right, so yes, my name is Dr. Katagira. I'm Winceslaus, a research scientist here, as well as the head of research and innovation. And I'm going to take us through the role of pulmonary rehabilitation in bronchiectasis. And I think as Adrian was introducing the topic there very well, you've already seen something like this. There are different types of bronchiectasis, but also remembering that in our settings, most of the bronchiectasis tends to coexist with other underlying lung diseases. So it's actually part of the description of the other damage that is happening to lung parenchyma. And in patients with bronchiectasis, usually the syndrome that you'll see is difficulty in breathing, productive cough, and I think Adrian talked about it there very well, that most of the time they tend to be at risk of colonization with certain stubborn bacteria, including Pseudomonas. So productive cough is a feature, as well as recurrent respiratory infections. Now, these over time will lead to deconditioning of the patient, and you'll end up having, the patient having skeletal muscle dysfunction, exercise limitation, as well as other mental-related, disabilities like anxiety, depression, and social isolation. Several mechanisms contribute to this, and I think, again, Adrian talked about it here quite well, chronic inflammation, but also you will end up having some bits of dynamic hyperventilation, ventilation perfusion mismatch, increased work of breathing, physical inactivity, all of these eventually leading to what we call the vicious cycle of deconditioning, where when the patient is quite sick, they prefer not to move because they fear that movement might worsen the underlying difficulty in breathing. And whenever you don't exercise or whenever you don't move, what actually happens is that deconditioning or the breathlessness on exercising actually tends to get worse. This is basically a summary of what I've been talking about, that although what we see when a patient comes into hospital is that sometimes they'll have cough, shortness of breath, sputum production, physical inactivity, and wasting, especially in the in the severe cases or even in the later stages. Of course, having probably appreciated already that bronchiectasis is permanent, and for some people it tends to be a bit aggressive, especially when there are other lung parenchymal defects that end up really affecting oxygenation and well, overall worsening the patient's clinical condition. But what we don't see is basically the secondary impairments that usually accompany chronic respiratory disease, where you have again the wasting that is as a result of the chronic, systemic inflammation, oxidative stress, skeletal muscle dysfunction, and then also the other things that would follow: the deconditioning, social isolation, anxiety, depression, and nutritional abnormalities. And this picture on the right basically summarizes what we call the vicious cycle of deconditioning, where when someone discovers that, oh my goodness, when I do this, when I do that, my breathing tends to become worse. So you actually start to see people avoiding exercise. So that exercise avoidance actually is very detrimental, and we tend to discourage it in across lung diseases. And that's why you see even for advice for patients with asthma, you will still hear patients or even parents to patients asking if the patient can sit out exercises, can stop swimming, can stop footballing and doing that, or, all those sorts. That actually is exercise avoidance that will make the patient enter into this vicious cycle. So with time, they will start to become very breathless, even with small small exercises, going up a slope, climbing upstairs. They become very, very breathless. So that's what we tend to avoid. There is only one treatment that is known, at least in pulmonary medicine, that can reverse this deconditioning. And that treatment is called pulmonary rehabilitation. It's like, all lung disease definitions. The definition does not disappoint. It's extremely long. But in summary, you have to know that it's comprehensive. That's number one. Number two, it is it is only offered when the patient goes through a thorough assessment. And that assessment will help you now tailor the therapies to that particular patient. That will include exercise training, education, behavior change, all of them designed to improve the physical and psychological condition of the people who are affected by chronic respiratory disease, including bronchiectasis. And you can see when we talk about it being a comprehensive intervention, you can see that it actually has so many things actually that are involved in there: baseline and outcome assessments, action plans, diagnosis and management of other comorbidities that you will find in the patient. You have to talk about breathing management, especially with patients who have a lot of difficulty in breathing. You have to take them through the breathing techniques that help them to preserve energy, nutritional support, energy conservation, interdisciplinary education. Sometimes patients will have conflicting views about their health and what they have heard people talk about, and they might actually take that as truth. So you have to keep on, educating them. Sometimes you might need other people to also come in to really educate them on a different things that they might need educating about. Then you also have to optimize pharmacotherapy and oxygen administration for the underlying diseases. Adrian talked about spirometry, and indeed, for most of the people with severe bronchiectasis, you'll find them with sometimes they'll have an asthma phenotype, and sometimes will have a COPD phenotype. So they will still need other treatments. He talked about medicines that help to break up the sputum so that they can find, coughing after sputum a bit easier. Especially because remember that their biggest problem is that they have damage to the airways, and because of that, they're having issues with airway clearance. So because of that, they tend to have a buildup of mucus in their airways. So sometimes you need medicines that are going to break up the sputum so that the patients can easily cough it up, or even when they go for physiotherapy, they can actually help to, percuss the mucus out of the airways. Okay. So again, this is a summary of what pulmonary rehabilitation is, and it is all designed to improve exercise tolerance, to improve symptoms, to improve the psychological well-being, health-related quality of life, as well as self-management for the patient. And it is really one of the most evidence-based non-pharmacological treatments for across a number of chronic respiratory diseases. And it's really a treatment that is whose background is in COPD. And for this, it has been comprehensively studied, and the evidence is overwhelming, so much that there is no longer any need for conducting clinical trials, for the efficacy of pulmonary rehabilitation in COPD. They officially declared them no longer beneficial because the evidence is just overwhelming. But in bronchiectasis, the evidence is a little bit smaller, especially because what is happening is that pulmonary rehabilitation is being, exported or tried out in a number of lung diseases. So in a systematic review done by Lee et al. In a paper that was published in 2017, they looked at so many publications around interventions of pulmonary rehabilitation in bronchiectasis, and only 4 RCTs actually made it. Only 4 passed the inclusion criteria. Those 4 included a total of about 164 patients, of whom half underwent exercise training and or pulmonary rehabilitation. Now, generally, across these 4 trials, I think there might be interference. I think someone help us to mute.
Okay, let me work on it as you go.
Yeah, sure. All right. So the programs across these 4 RCTs generally involved supervised outpatient exercise training, aerobic and strength exercises, education components, all of them lasting at least 6 weeks. And we'll probably talk about why they have to be aerobic, why they have to be at least 8 weeks. And usually we prefer that they should be supervised, for you to get the desired effect. Now, the summary of these 4 clinical trials is that when you compare, patients with bronchiectasis with those in COPD, the patients with bronchiectasis still experienced improvements in exercise as well as health status outcomes, just as was seen in patients with COPD. And this it was really against this that, for most settings where it is possible, there is a very high recommendation of including pulmonary rehabilitation in the routine clinical provision of patients with bronchiectasis. So it is always part of those treatments that are offered. So now, when you look at, again, the components that would, for a patient with bronchiectasis, their the key components of pulmonary rehabilitation will still center around these 3. Airway clearance, which again, Adrian talked about, to just make sure that, whatever mucus is built up in the airways is cleared, and we will go through some of the pictures there to show how. And then after that, take them through exercise training. This is the only treatment that is known to reverse deconditioning, by helping build up someone's fitness. Again here, if I forget to mention it, I can mention it here. A fit muscle utilizes very little oxygen compared to unfit muscles that need a lot of oxygen to actually do the activity. So when a muscle is fit, you're not replacing someone's lung, but you're helping them utilize whatever little they have. You're helping them to utilize it very efficiently. And that's basically what exercise training does in pulmonary rehabilitation, to make the muscle as fit as possible so that the patient can use very little oxygen to perform the activities. And by doing that, you actually realize that the patient can move faster, can go about their business without really, needing oxygen or without getting tired. And again, I've talked about self-education, and this really cuts across many things, including the patients knowing how to recognize that they might be experiencing an exacerbation, what they need to do, the first things that they need to do, and also when they should go to hospital. So we published a paper to differentiate between pulmonary rehabilitation and chest physiotherapy, because most of the time when people hear when they hear pulmonary rehabilitation, their minds usually run very fast into what they know as chest physiotherapy, which is basically one of those airway clearance techniques. You can actually see here The pulmonary rehabilitation is quite comprehensive, includes, everything that we talked about, including assessments, exercise training. You have to, when you talk about health status or improvement in health-related quality of care, or health-related quality of life, that is usually done using questionnaires to basically see that at baseline, they were at a certain level, and when they go through the entire exercise or the entire program, you actually see an improvement in their health-related quality of life scores. So that's why, for almost all pulmonary rehabilitation programs, will have a questionnaire to somehow, see that you actually are adding value to the patient in helping them improve. And it goes, around that exercise, training, endurance, and muscle strengthening. And it doesn't stop in hospital. You will still encourage the patients, how to continue performing these exercises at home so that they do not lose the benefits of pulmonary rehabilitation. Okay, so this is just an example of the different techniques in chest physiotherapy. You basically are trying to help, the patient. You are trying to help to clear mucus from the airways, depending on the location of the bronchiectasis. And so you keep on, targeting the segment that has the most buildup of the mucus. And once you get it, you will, so these are all, I think you can see in these pictures, the points where you will be percussing or where you'll be applying the different techniques. So depending on where the bronchiectasis is, and these are also the angles that show you how you should position the patient, where the head should be and where the legs should be. You can see, some of the commonest positions there. Sometimes the head has to be higher. Other times it's really the limbs that are supposed to be higher to help to clear up the mucus buildup in the different segments where there might be the buildup of that mucus. And these are the techniques you can do: posture drainage, percussion, vibration, huffing technique, or even coughing to help to clear that mucus. Now, what is different is that in pulmonary rehabilitation, we are targeting the muscles that we use to participate in activities of daily living. And you can see we have muscles of the upper limbs and muscles of the lower limbs. The upper limb muscles are the ones that usually help you to carry around things, carry a jerry can, peel your onions, lift kettles and saucepans from the cook stoves to really help to prepare your meals. While the lower limb muscles are the ones that help you to move up and about. If you want to go to the market to buy some things, you will use mostly the lower limbs. So you will have to combine exercise for both the upper and lower limbs, so that when these muscles are built up, eventually you'll have reduction in oxidative stress. Then you will also help to shift the muscle fibers from those who are easily fatigable to the fatigue-resistant muscle fibers. And eventually what you'll have is a person who is a fitter and can actually go about their work. Overall, I think as Adrian said, in our settings, probably post-TB lung disease is the commonest cause of bronchiectasis. And that's why you see it will still be one of the things that we describe post-TB lung disease with either a pulmonary collapse, bronchiectasis, aspergillus, and things like that. So usually when you find such a patient, they are patients that are going to benefit from pulmonary rehabilitation. So this is just an example of the setup of the pulmonary rehabilitation at the Lung Institute in the Pulmonary Rehabilitation Center. And again, a combination of education and the different stations where you exercise both the upper limbs and the lower limbs. These sessions are usually given twice a week for a total of about 6 weeks. And it's because you have to give an exercise dose that is sufficient enough to bring about psychological adaptation, to bring about cardiorespiratory conditioning, to improve peripheral muscle, the strength in the peripheral muscles, as well as basically reversing the whole deconditioning and overall improvement in the patient function and conditioning. So that's why you see they have to be at least 1 hour of exercise and done twice a week. And even when they go home, we tell them that during the non-rehab days while at home, they should continue performing their exercises. Now, I think this is really what we've talked about as the benefits. We'll probably be going through that eventually. You'll see that patients, number one, will be able to move up and about with ease, but also their symptoms overall will become better, loosening up secretions, making it a bit easier for them to breathe. They can easily also cough up the mucus, and by doing that, you reduce both the chances or the risks of exacerbations as well as hospitalization. So this is just a summary of probably in about 3 slides of the randomized control trial that we conducted here at the Lung Institute. It was a single center RCT because, I mean, in Uganda, we have only one PR center. By that time, we had only one center that we could conduct this trial from. Adults with post-TB lung disease, most of them had bronchiectasis, were included into this trial, and we used what we call the incremental shuttlework test as the an outcome of measure that really objectively measures someone's endurance level or exercise capacity. So we measured it before the exercises or before the pulmonary rehabilitation program and after. So again, patients were grouped into two, either to be offered pulmonary rehabilitation or usual care, which usually just included, if you have an airway syndrome that needs inhalers, we give you inhalers. If you are smoking, we advise you to stop smoking, and overall to avoid biomass smoke because that can easily exacerbate the underlying airway syndrome. So a total of 114 were randomized to each arm to receive either pulmonary rehabilitation or usual care. And what we generally saw was that most of the participants had some bit of airway syndrome, and that's the box that you see there. This is I think almost 70%, 2/3 of the patients had some sort of airway syndrome, either COPD or an asthma syndrome or even restriction, and most of them actually needed to be on inhalational therapies. So at the end of the rehabilitation, you actually saw that the patients, those who were offered pulmonary rehabilitation, significantly improved in exercise capacity compared to the usual care, where they were really just doing business as usual. Again, demonstrating here that pulmonary rehabilitation significantly improves the physical conditioning of the patients or of the patients with chronic lung disease like post-TB lung disease as well as bronchiectasis. And overall, we also saw an overall improvement in the secondary outcomes that were mostly pointing towards quality of life. So we also saw that for the patients who were offered pulmonary rehabilitation, you saw improvements in the health-related quality of life scores. And when they were subjected to the cost-benefit analysis, the program was proven to be beneficial cost-wise, when you compare those who are in rehabilitation versus those who are in usual care. So in summary, when you look at bronchiectasis, the prognosis is combining again the presentation here and what Adrian talked about. There are so many things that are going to influence the prognosis in bronchiectasis, including number one, the severity of lung damage. Number two, the frequency of exacerbations. That's why you see we have to do whatever we can to reduce the risk of exacerbations, because the more someone gets exacerbations, the poorer the prognosis. Lung function, Adrian talked about needing to do spirometry, because if you just target their airways and cough and all that, and you forget that actually they might also have probably very severe COPD, a very bad exacerbation can actually take them. And then you also look at the overall health of the patients. Are there other comorbidities that are going to need attention and things like that? And then other lifestyle factors. You don't want anyone with lung disease to be smoking tobacco at all. If they have any form of addiction to tobacco smoking, you want to offer them addiction prevention and treatment to tobacco. And so overall, you will see that the prognosis is variable depending on the stage at which the patients are. Some people actually have very limited bronchiectasis, and they just go through life without really having any issues at all, because overall lung function is good, damage is little or minimal, spirometry is not that bad, the risk of exacerbations are very minimal, so they have a favorable prognosis. While for others, usually you have to really keep all these things at the back of your mind, the vaccinations, antibiotics, where needed, other pharmacotherapies to treat the underlying diseases. And I think I already talked about it, that it's a permanent disease and it's not curable. So you really just have to control the disease wherever we can. We talked about treatments that make a difference, including airway clearance, treating underlying diseases, vaccines, pulmonary rehabilitation. And overall, when everything is really in check, usually you'll be able to extend the patient's life several decades if you do the right things. Thank you so much. I will end here and take any questions.
Thank you very much, Dr. Katagira, for a very wonderful talk on pulmonary rehabilitation. Much appreciated. At this point, we welcome anyone who has questions. Some have been posted in the chat. Seen Dr. Wincy, this may be yours. Do we have bronchiectasis registry in Uganda? So please raise your hand so that we can check out. I see Dr. Baluku has a hand, then Joel and Okirol. So maybe we can take those three first. So we are going to take the first question from Dr. Baluku, the next one from Joel, the next one from Okirol, and if I saw well, Dr. Mwota has a question. So in that order, we can take them, then we can see how they can be answered. Over.
Actually, the question is from Edwin. Please go ahead. He's using my account.
Adrian Mwota.
Yes, thank you, Ahmed, and apologies for some reason my link wasn't working. This is Edwin Wajira, and I work at MAST. Thank you, Doctors Mwota and Katagira, for the great presentation. I have a few questions. Dr. Katagira mentioned a little bit about vaccines, and we have had a cohort here in Bara where we looked at patients who had post-infectious bronchiectasis, and most of them had growing strep pneumo, and we tried to get them vaccines and after treatment, and that was very hard. I don't know how you're doing it at the Lung Institute. Do you have vaccines like the pneumovax for adults? Number two is about pulmonary rehabilitation. So in some of these patients with chronic lung disease, we've tried out rehabilitation, but our biggest challenge is undernutrition. And because of the undernutrition, they don't sustain the exercises up to the 12 weeks that we prescribe. In addition, many times we just talk about pulmonary rehabilitation. With the exercises, we don't have like a feeding component attached to it. What do you have to comment about that? And then the last question is about, the cogwheel of exercise, which is muscle strength, cardiovascular functioning, and respiratory functioning. Do you have a comment about cardiovascular assessment, or how do you pre-assess them for fitness for these exercises, in terms of cardiovascular functioning? Thank you.
Thank you. Next person.
Thank you
Joel?
so much. Good afternoon. Thank you so much for the presentation. This is Joel, critical care physiotherapist at St. Francis Hospital in Zambia. So my question is going to go to the setup in the single randomized controlled trial that we did, the setup for the pulmonary rehabilitation. We see that the best pulmonary rehabilitation team is one that utilizes the multidisciplinary team, one that has several members playing particular roles. So I would like to ask if in the single randomized control trial that you did, or in the setup, the pulmonary rehabilitation setup that you have currently at the Lung Institute, what are those specific members that you're having on the team? that they said this one having, doing this role, or we have a physio, or we have this, or we have this. Yes, thank you.
Thank you. Next. Okay, roll.
Thank you very much, Chair and presenters, for those very wonderful presentations. I have two questions, and one is based on the epidemiology that Dr. Adrian presented, and I think probably bronchiectasis is really underdiagnosed. I think probably we could look at seeing how to simplify the diagnostic criteria, especially for clinicians who interface with the potential patients on a day-to-day basis, so that we have a heightened index of suspicion to identify these cases. This is probably one of the approaches we could use to see how to improve those numbers and have something for Uganda at the very least. The second issue, I'm just curious. There is a practice that has seemed to have cropped up, especially during COVID-19, of patients doing something they call steaming. And I'm just wondering, does steaming have a role in pulmonary rehabilitation, if any? Thank you.
Thank you very much. Maybe Paul Mills, you can use 1 or half a minute. Then we first take those.
Thank you. Just a question about pulmonary rehabilitation. Is there an awareness week in Uganda? And one thing that we've done in England that is spreading, we're having people who've completed pulmonary rehabilitation speak to university healthcare students before they graduate, so they can have a better understanding of the patient experience of pulmonary rehabilitation. Thank you.
Thank you very much. To Simi Christabel, please put in the chat. Dr. Wincy, can you take those for now? Adrian, is your hand up? Okay, over to Wincy for now.
Okay, I am hoping I picked everything. It looks like at some point I might have jumped off, but I hope that we said with Nwajira, who asked about availability of vaccines, and then PR and nutrition, as well as cardiovascular assessment. Now, so the vaccines actually are available, but at a cost. So for now, patients actually are able to buy the vaccines. At least the pneumo is, especially that one is a little bit expensive, quite expensive. But at least they get a chance to, I think, receive it once up to the age of 65 years, and then see if they'll need it thereafter. What we see, and again, this is going to link a little bit into probably your other question on cardiovascular assessment. Actually, the patients that we have are quite young. Our pulmonary rehabilitation patients are young compared to the cohorts you see in the UK and other high-income countries. Our patients are quite young. And again, this is because the biggest driver of the need for pulmonary rehabilitation in our settings is post-TB lung disease. And that, unfortunately, tends to be really, really in very young people, which makes, I think, the need for its availability even more, because when you look at the effect of these chronic lung diseases on the quality of life of people and their productivity, eventually the impact on their productivity, it's really quite immense. So I think the faster you build them up, the better. So I think that's where we are in terms of this. So yes, for a good number of people who need a vaccination, we can prescribe for them the pneumococcal and then the annual influenza injections, and they've been at least quite available, but at a cost. So it's still really, again, an out-of-pocket expenditure. Then nutrition actually was quite interesting that you picked it up. So in our programs, actually, for all the studies that we've done in our programs, we did offer food as part of basically before an hour or two before they were rehabilitated. And I remember when I was during my PhD defense, it came up as quite an interesting discussion here, because food is not usually part of pulmonary rehabilitation programs abroad, but in our settings, doing that alone in the first pilot, what we saw was that actually people were putting on weight during the rehabilitation. So I think that is something that usually where it is part of the program and it's not, again, a study where you're offering meals, it's probably something that we bring together families and discuss how to support, these patients. We also had a nutritionist. I think someone else was asking what our multidisciplinary team actually included. We had a nutritionist who also taught, who taught and still teaches, the patients, especially those who are undernourished, about nutrition, which foods, there are foods actually which worsen breathlessness. There are foods which are good for, building up muscles and things like that. So it's really usually quite a comprehensive education session around nutrition. So again, because it is tailored, if someone is weak because they have not eaten food, especially because there are discussions about these so-called catastrophic costs, you actually see that in the post-TB phase, they continue to affect the survivors, especially because they are no longer working. We see that for those who have been severely affected, they somehow lose jobs, and because of that, there is a little bit of struggle in affording food and things like that. So again, it's a probably bigger discussion on how this can be supported. Yes, and then for the multidisciplinary team, we actually have a physiotherapist, we have a doctor, we have a nurse, we have a counselor, and a nutritionist. So that actually is what our team comprises of, and usually we work together to just on one participant. And many times you have to discuss, so many things, including needs and optimizing treatments and things like that. Steaming has no role in pulmonary rehabilitation. It actually also generally has a very limited role in lung diseases overall. Maybe if someone wants to make the skin of their face look younger and nice, maybe, but overall steaming, especially because people really put in all manner of things in there, for some people it actually tends to worsen difficulty in breathing, because sometimes they will put in things that are quite inflammatory to the airways. And I think you people know, sometimes they put in weeds, at times they put in substances. So generally we discourage steaming in our clinic. Whole meals are very interesting, but actually you're doing a lot of work in the UK. Again, wonderful work, I think, across board, pulmonary rehabilitation wise. So I think for now, most of the, I think, awareness has been in the medical school at the master's level, because by the time I started this work in pulmonary rehabilitation, it was not even available in the curricula or in the usual, topics of study or discussion. But that is changing, and there is actually more noise and awareness basically around pulmonary rehabilitation overall. We also are involving patients as much as possible, but of course, the interesting thing is that the treatment itself, even from some of the studies we've done, is not yet well known actually amongst the doctors who would have been the ones referring. But also, there are also challenges around availability. We've done a lot of work, but we are still in really, again, baby steps compared to where we want to go. But we are much better than really where we were 5 years ago. I'll probably stop there. I hope
Dr. Wince, you have some questions on the role of PR in chronic bronchitis and asthma, and how much bronchiectasis may be found in sickle cell disease?
Wow.
And inverse question about a registry of bronchiectasis in Uganda. Over.
Oh, okay. So I can say that we don't have a registry of bronchiectasis in Uganda, and I think there are also issues around diagnosis. An expert eye will see bronchiectasis on the chest X-ray, but otherwise it will mostly be missed. Usually, the best diagnostic, modality that would really bring it out would be CT. But we know, I think the cost of chest CT tends to be quite prohibitive. But so the simple answer to that bronchiectasis question is no. We actually do not have a registry. Ahmed, I think you may need to remind me the others.
The other one was asking burden of bronchiectasis in
sickle cell
disease. I think like since they get PhD and all.
Yeah, so I think a quick one to that, we don't know, but we usually know that the main lesion probably when it comes to lung disease in sickle cell, most of it will be lung parenchyma, especially with those micro infarcts. So when even when you look at the spirometry, it tends to be restrictive, and it's usually attributed to probably the small micro lung parenchyma destruction. For bronchiectasis as being caused by sickle cell, I'm not aware, and I don't think we know that. It's not something actually that I've encountered before or even read about, so I don't think I can answer that.
Then very quickly, the other question was the role of PR in chronic bronchitis and asthma.
So chronic bronchitis is really an umbrella term that usually you would find in COPD. So usually when it is available as COPD, yes, definitely there is a role, especially if the chronic bronchitis is going to end up, affecting people's ability to move up and about. It's going to affect their ability to move. Usually, because again, you basically are trying to recondition them, being able to build them up and so that they get back to their best fitness levels that they can keep them productive. So yes, definitely there is a role, and as I've said, I think the most overwhelming evidence of PR is in COPD. Bronchiectasis being a subset of COPD. Asthma, there's also quite a lot of literature that again suggests that pulmonary rehabilitation is very beneficial, especially in severe asthma. It's especially because that's actually where you're going to expect a lot of exercise limitation, and those are usually offered pulmonary rehabilitation.
Okay, thank you, Dr. Wincy. One last one is a recommendation from Ranga Alex that in future we might need to add physiotherapists on the presentation so that they guide other physios or anyone else on the techniques themselves. Then the other one, maybe myself, I will ask you, is one round enough? Do we have any reversal in gains? And maybe I can ask Frances Nanyunget also ask the question quickly so that we finish in 3 minutes. Over.
I think Adrian also had some questions to answer.
Oh, okay, wonderful. Adrian.
Yes, thank you, Dr. Wincy. You may have actually pointed out some of the questions that were pointed to me. Others were actually acknowledgement of the current epidemiological challenge that we have right in Africa, the lack of data, which, like you pointed, could also arise due to the limited diagnostics and it being very expensive. Others are actually good actions for us going forward, like the National Pulmonary Rehabilitation Week to increase awareness. But I would say this is a good start when it comes to pulmonary rehabilitation. I think others you have spoken to them, unless I have missed any.
Okay, thank you, Adrian. Nanyunja, Please
Thank you
ask
so
the next question. Go ahead.
yeah, thank you so much. Thank you so much for the presentation. I must admit I enjoyed the paper that was on the difference between chest physiotherapy and pulmonary rehab. I thought it was really good, and I applaud the team for that. Mine is really a question for someone who's doing pulmonary rehab at the moment, and where do you see that the implementation going? Because it's from moving from RCTs to more, really rolling it out into the tertiary institutions. What are the future steps, and what are some of the leading things from your studies you have done that could enable us to implement such programs within the other public sectors within the country? Thank you very much.
Wincy, please take it on
Yes.
so that we can
Okay.
close.
I think you
Yeah,
had
in the chat, allow me to
your
say
first
this also.
question.
My first
I
question
think
was,
yeah.
go ahead. Yeah.
Your first question?
No, the first question was, do we lose gains when we do one round?
Yes. Yes,
Go
I'll
ahead.
start there. Yeah, I'll definitely start there. So I think the same way, if any of you has a routine of jogging, you know that the more you jog, the fitter you become. But when you actually interrupt that jogging, even for a few months, you will struggle to actually go back on the jogging track. That exactly is what we see in pulmonary rehabilitation, that actually there is loss of gain. That's why, number one, patients can actually enroll as many times as they wish. Number two, there's always that question is how do you maintain the gains? And that's where, the biggest challenge is, because usually after you've done the group rehab where people are usually motivated, they enjoy group participation, because then it's not just exercises as a group, but also, just chatting with other people and just catching up. Those are some of the things that really make people look forward to coming for rehab sessions. But the moment they go back into the communities, they really struggle to do the exercises alone. It gets a little bit boring. But for those who are a bit enthusiastic, they somehow maintain the gains and they continue doing the exercises that they learned from the center-based rehab. They continue those actually at home. So yes, there is actually loss of those benefits. If someone does only once, it's the gains are not permanent and pensionable. They can actually be lost. And then there was a question on where are we going with rehab, after all this wonderful work that we have shown in papers and things like that. We actually are advancing quite a bit. The ministry, it has been taken up at the national level, and there are high-level discussions ongoing to roll this program at this as much as possible. We did a pilot about 2 years ago. We did a pilot where we did implement pulmonary rehabilitation in health centers where patients go for TB care. And it was actually quite interesting that people were able to offer pulmonary rehabilitation with the basic questionnaires that we used. There were still gains across board in improvement, both exercise capacity and health-related quality of life. So, but I think we appreciate that there's also some bit of significant improvement significant investment required, both in human resource training, but also the setup of the centers, and also the referrers, the people who refer to the programs, also need to be aware, so that when they look at this patient, they know that this is someone who will definitely benefit from pulmonary rehabilitation. So those are still some of the challenges, but I will tell you that there are actually huge strides that are being made at the national level to try at least to make PR as available as possible across the country, at least in the big centers where physio spaces exist. And I think Adrian can speak to this as well. Adrian, please come in and add to this as well.
Okay. Kindly, I will draw everyone's attention to the chat because we have exceeded the time. Adrian, as you come in, I think maybe Wincy or Adrian, you can put your emails. If you have a slide, let us your email so that people can share more questions even after the session is done. Adrian, would you have more comments on the same?
And no additional comment, but just to add on that, like Dr. Wincy mentioned, that we are actually trying to have increased focus on building capacity, especially in pulmonary rehabilitation. We know it is very important and very key part of the management modalities, not only for bronchiectasis, but it spreads wide to patients that are having chronic respiratory disease. And we also know it also actually stretches and intersects patients that are also under cardiovascular management. So please kindly refer patients to Lung Institute. We offer this service at the Lung Institute, and definitely the assessment is always done to ensure that those that fit the criteria are actually enrolled in pulmonary rehabilitation. Back to you, Chair.
Thank you very much. I think that's a wonderful closing. Although there is one burning question in the chat, they are asking for how does an affordable pulmonary rehab look like in an African setup? And someone is asking, is there any role, unavailable modality, given our difficult transport system? Is there any available modality of tele pulmonary rehabilitation? I think that might be the last one, and then we close, in case any of you can take that.
Okay, so I'll probably start with the tele pulmonary rehabilitation. And again, I'll have to say that we are not seated. We are really continuously innovating around how to make pulmonary rehabilitation as widely available as possible, especially because we just really can't assume that one center can serve the whole country. But we're also working around trying to digitize, the training of pulmonary rehabilitation, because it's so that there is some bit of standardization and especially assessments, because you need to really be sure that you have assessed the patient quite well before you take them through all the exercise intensity that you're going to do. Because you can imagine if someone has, as an example, a massive pulmonary embolism and you want to take them through all those exercises, the patient actually might collapse on you and you actually wonder what's going on. So that's why that training is quite important. And we don't rush to rehabilitate until you have properly done a baseline assessment and screened your patient and seen that this patient is actually safe for pulmonary rehabilitation. For those where you have doubts, you always, and that's why you see in our team you have a doctor, you have a physician who will assess to make sure that the patient qualifies for pulmonary rehabilitation. Yes, so telerehabilitation is something that we are exploring. We already have some bit of work that has already happened in trying to see how we can, adopt all these things. We are working together with our colleagues in Leicester, in the University of Leicester, who have been our mentors, and we have done quite a lot of work around that. So we want to see if there will be options of rehab where people really can even from the farthest center from Kampala can actually go through the whole training and be able to offer pulmonary rehabilitation quite safely. What does a low-cost pulmonary rehabilitation program look like? A low cost is basically where you use the cheapest cheapest equipment to deliver a pulmonary rehabilitation program. Most of these really include chairs and steps and weights. Those things, all of them can actually be adopted very cheaply. I think where the cost might come in is this actually being a multidisciplinary kind of intervention. It's not a one-man show. It's not a one-man star. It's really a multidisciplinary team, a team of people who assess, who look for these things, and that's actually where probably some bit of care needs to be put. But for other things, I think all other centers, all other exercise stations can be innovated around. The exercise bike, there is some bit of innovation that can happen really around that, so that people can still have endurance exercise stations. Yeah, so that's actually what I would respond to. Thank you so much. Over.
Okay, thank you very much, Dr. Wincy. At this point in time, I would like to invite the Principal, College of Health Sciences, to give us some remarks so that we can close the day of lung science. You're welcome, Professor.
Good afternoon, everyone. Thank you for attending the meeting. It's good to see, can I say that pulmonologists leading these discussions independently. And that's our aim at the Lung Institute and the college, that we produce competent and confident and independent clinicians who can drive lung science in the country. That's all I can say, but all I can tell you that most bronchiectasis actually in our country goes undiagnosed in the most cases. In the recent use of X-rays to screen for TB, we are seeing a lot of structural lung diseases, which actually people are living with in the community. That data was presented by the TB program. I think as the Lung Institute, we should interest ourselves to scrutinize those X-rays to come to the final diagnosis. In the community level, they say the lung is abnormal, looks abnormal, but what is it that is abnormal? Thank you so much.
Thank you very much, Prof. Much appreciated. I thank all of you. We can make a round of applause for our presenters, and we declare the Day of Lung Science closed. Thank you, everyone. Goodbye.
Thank you.
Thanks.